Just got home from work. Had a good amount of patients today. Finished a little early, which is really nice. So I'm about to eat breakfast. Diagnosis that a lot of times gets looked over, and one of that, of course, is going to be eating disorders. So there is a patient that had been to multiple psychiatric hospitals in the past. I asked about binge purging behaviors. Not a lot of doctors ask enough questions about that stuff. And all you gotta do is, hey, some safety questions. I'm all about your nutrition. Do you do any restriction of calories because you don't look good? Do you make yourself vomit because you feel sick to your stomach or you feel like you weigh too much? They're not normal behaviors, number one. Number two, there's a lot of repercussions that happen as far as electrolyte imbalances and just albumin issues. The other diagnosis that I wanted to talk about, which can get overlooked, is called PMDD. It's premenstrual dysphoric disorder. So patient comes in, relapses, and there seems to be this pattern: high anxiety, cannot sleep, irritable, lack of patience, lack of impulse control, eating a lot more. When those things are kind of falling into place, you must ask them what their cycle is like or when their last period was like. Because if it's PMDD can occur a week before the first spotting happens, before the first day of bleeding. A week to a week and a half, you can ask them, do you see an association with your cycles, with these moods that you're getting? Because a lot of times it can be misdiagnosed as bipolar. So ask them, hey, like, what happens 1 week to a week and a half before you get your period? And once you do get your period, do you all of a sudden feel better? So ask them those questions for a patient. I've only diagnosed 3 patients with PMDD in the last 2 years. And treatments for it, man, it's hard. It depends on what it is. Some people with PMDD will get almost psychotic. Some of them I have read online that they have gone to psychiatric hospitals because of suicidality. So with that, assess your risk first. So if they're acutely suicidal, of course, send them to the hospital. But what I prescribe, it depends on the severity of it. Once they're already on the max dose of an SSRI and everything else is treated pretty well, no blood pressure issues or what have you. If there is a insomnia and severe anxiety that happens with a person who has PMDD, I will either add a lamotrigine. Starting dose is 25 milligrams daily. That titrates up every 2 weeks, doubling up. And if it's more acute and they are like, oh my gosh, like panic attack, haven't slept the last 5 days, maybe 1 or 2 hours, really risky behavior, I would probably do a 25 milligram Seroquel or a 50 milligram Seroquel at bedtime. You can do an extended release. What's good about Seroquel is specifically it works a little bit faster than the lamotrigine, of course, but it depends on your patient. Typical treatments for PMDD is a low dose Prozac 2 weeks before the start of your period. The thing is with SSRIs, you never know, especially with people who have substance use disorders. There's like underlying bipolar to where it can cause mania. So just keep an eye on that. So those are the 2 diagnoses that tends to get overlooked: eating disorders, binge purge, restriction behaviors, body checking, mirror checking, wrist checking, whether it's their size. Second disorder that gets misdiagnosed is premenstrual dysphoric disorder. So hopefully you guys enjoyed that. I'll see you later. Thank you so much for supporting. This weekend I reached 500 subscribers on YouTube, and I appreciate you liking and just sharing my material. Thank you.